If you're building your ABA company and you're tired of guessing, this is for you. We built the BCBA blueprint to give you real structure, systems, and support without the fluff. Details are in the description.
Welcome, everybody. We're going to be working with Mandy Ralston of Knowetic, and anything that we can do to make our team sharper, more consistent, and faster, more productive, to expedite or improve our outcomes. We want to look at those things. So from a business standpoint and from an outcome standpoint, these are the important kind of tools we want to learn about. And Mandy's going to introduce us to Knowetic, its decision model, its AI, its HIPAA compliant chart research, medical records research. This is a great tool that can kind of cover all those things. Really excited to hear about it. Mandy, welcome.
Thank you, Derek. Appreciate it. Thank you, guys, those of you who are attending live, and hopefully a few more of you will be catching this via recording later. But yeah, I'm Mandy Ralston. I am the founder and CEO of NonBinary Solutions, and our product is called Knowetic.ai. That's our flagship product. It is a clinical decision copilot software as a service. And so it's subscription-based. We have 3 major modules on the software at this point. The first one is called Care Navigation, which is a really robust and dynamic intake process. The second one, and Care Navigation, I should say, is on version 8.0 currently. We've reiterated that multiple times based off of user feedback. Our second module is something called Goal Development. And so that is designed to tie medical necessity to socially valid outcomes and recommended assessment tools and write goals for the user based on an interview process with the family or the patients. And that is currently in beta. And so we are looking to bring more users on board to get feedback on that module so that we can continue to iterate that and get it as clean and spiffy looking as the Care Navigation module is today. And then the third module, which will be released in the coming month, is the intensity forecasting module. And that is, of course, making a recommendation about clinical dosage, including hours per week, location, modality, etc., based on how you have entered the rest of the information from the first 2 modules. So we're excited to release that as well. But as we get started here, I'm going to take you through a little bit of the history of how we got here, why I started developing this particular product. I am a 26-year clinician. I built 2 different clinics in Kentucky where I live. I sold the last one in 2019 to the 4th largest ABA provider in the US at the time. And then once I was inside that organization, I started to see the problem that I'm now solving for. And I also started learning about designing these clinical decision software systems. So part of the problem, of course, here is that we've had a 250% increase in the rate of diagnosis of autism in the last 25 years. There's lots of different reasons for that, but we're not going to go into the details of that. You can catch that on a different talk that I do on a regular basis called #It'sNotBinary. But yes, we've got approximately 1 in every 36 individuals are diagnosed with autism at this point. But to top that problem, the real issue that I saw once I was inside that larger organization with all these different acquired clinics is that no 2 clinics and no 2 clinicians are doing anything clinically the same way. So we've had a 500% increase in providers in the last 10 years, and over half of the field now has less than 3 years of experience, right? And there just aren't enough old folks like me around to actually mentor or train or support all these younger clinicians the way that I had mentorship and support as I was coming up through my early years. And so I think that this clinical software is my way of being able to help a large amount of people very quickly rather than, trying to spread myself thin by mentoring just a few folks, right? So yeah, we've had this rapid increase in the rate of diagnosis of autism in the last 25 years. And part of what I think's going on here is that we had a technology that was adopted between 1995 and 2000. So if you look very closely there, when you look at 1995, the historical CDC data said that autism diagnoses were 1 in every 1,000 individuals, right? And that's when the DSM-4 was enacted. That meant that we had 5 different diagnostic codes. We had autism, we had pervasive developmental disorder not otherwise specified, we had childhood disintegrative disorder, Rett's disease or disorder, and also Asperger's syndrome, right? So in 1995, it was 1 in every 1,000 individuals were diagnosed with autism. Also in 1995, if you look at the top point there, it says 3% of Americans have used something called the World Wide Web, right? So that was the very early days of the internet, and the internet screamed at you when you logged on through a phone at that point, and your mother also screamed at you to get off the computer so she could use the phone. So that's the internet in 1995. Now, if you look up to year 2000 there, we have a rate of diagnosis of 1 in every 150 individuals. So we went from 1,000 to 150 in a span of 5 years. Also, what's happening in 2000, it says that 78% of Americans have downloaded music at this point. And so I'm illustrating here the rate of adoption of this relatively new technology, the internet, and what happened in those 5 years, right? And correlation is not causation, right? But I point this out because I think that there's a good thesis here that what happened with the internet, partially, is that people were able to start sharing information quickly, right? And so they were starting to be able to say, hey, your son sounds like my son. What is your son? Does he have a diagnosis? What is autism, right? What are you doing with your son? Oh, what is applied behavior analysis? Where can I get that? How do I do that, right? And so people are starting to find each other, and you see this steady increase as the rate of diagnosis goes up. We've also got the introduction of Autism Speaks in 2005. And what do? They come out with a campaign of awareness and support. They come up with a whole campaign related to autism, or April is Autism Month. April 2nd is World Autism Day. They come up with the puzzle piece, and say what you will, like or you don't like, Autism Speaks. But they did get the information out there, and people were able to start sharing information and finding each other faster, which was part of the reason that we saw this grassroots movement within the parents, that they understood that Indiana in 2001 was the first state to pass a mandated insurance treatment law, right? And so they started this grassroots movement in order to get insurance coverage in their states, right? And so by the time you get to 2012, we're now at 1 in every 69 individuals is diagnosed with autism, and over half of the United States has a mandated insurance treatment law passed in their state, right? And there are only 10,000 board certified behavior analysts worldwide at that point. So you can see that we've had this influx of the diagnosis rate. We've had an influx of coverage within treatment, but a very slow growth rate of seasoned providers by 2012. And so that's how we get to this area where we have, again, 500% increase in the last 10 years, and over half of those providers have less than 3 years of experience. Now, to further complicate the situation, the DSM-5, when it came out, it got rid of those 5 different diagnostic codes that we talked about, and that instead they put everything under one diagnostic code of F84.0, which is just autism spectrum disorder. So there is no longer an Asperger's syndrome within the DSM-5. And so even though it was already heterogeneous, it's gotten even more heterogeneous in terms of who are all these very, very different people that have a diagnostic label of autism. You've got everything from, on one end of the spectrum, individuals that have profound autism and will need 24/7 care for the rest of their lives in many circumstances, to the other end of the spectrum that you've got a guy that gets called into HR on a regular basis because he's perceived as being rude in his workplace, right? And so how do we actually come up with individualized, appropriate treatment pathways for this very, very different group of people, right? Like saying that any child with autism between the ages of 2 and 6 needs early intervention, intensive intervention for that matter, 20 to 40 hours a week. That's not a clinical decision. That's an operational decision, and that's a binary, and it's way too simplistic, right? So having autism or not having autism is not a binary either, right? It's a very gray area. It's not black and white. And so in order to treat people appropriately, we have to see the full amplitude of their humanity, okay? So again, I can get 100 behavior analysts in the room with one patient with autism and say, how are you going to approach treatment for this person? And they all have drastically different ideas about how to approach it. And most of the reason they do it that way is because that's how they've always done it. That's what their mentor trained them to do. That is their particular philosophic background, etc. It's not necessarily based on the most recent data or literature or best practices. It's just what they do, right? Even to the extent that our field sort of has an existential crisis at this point, that we have yet to sort of agree as a group what are our outcomes that we're reporting on and what are the various outcome measurements, right? So we've got sort of this general understanding that outcomes refer to the results or consequences that arise from specific activities, processes, or situations. And that could be including personal, educational, medical, or organizational settings, right? Those are what outcomes are in a general sense. And so we need to have an understanding about what is an outcome versus an outcome measure, right? And we've had some different outcome frameworks be released within our field. We've had some from the Behavioral Health Center for Excellence, which is now called Jade Health. We've got the International Consortium for Health Outcome Measures, or ICHOM, and we've got the CASP recommendations that are also available. But those are all frameworks for selecting different assessment tools and don't necessarily talk about what an outcome is specifically, and that's part of what I think we need to get down to. So one of the first things that I'm trying to solve for with the Knowetic software is the lack of training or standardization in a clinical interview or a clinical intake, right? So again, I could get 100 different providers in a room and say, okay, how are you going to approach this clinical intake with this person? And they will all have sort of personal versions of what that might look like. You could get, 10% of the same questions across those 100 different providers, potentially. You might get 80% on a different type of question that all of them are asking, but generally speaking, it's pretty heterogeneous. And so what's important about our software and how we are approaching bringing patients into a data set is that the interview process within care navigation is standardized and structured in a way that each patient at the core of the data set are brought in exactly within the same parameters, right? And that means that we can actually compare patient data to patient data when we track them over time through their outcomes. Because if we didn't bring them all in a homogeneous way, that they were all standardized and structured as a data set, then that means we would be comparing apples to oranges, right? And so the same questions asked to patient A were not asked to patient B, and therefore there are gaps in the data, right? So it's important that this initial sequence, the care navigation module, starts off in that way. Okay? And I'm going to take you through a little bit of that today, and I think we're going to sort of have a series of this webinar where we sort of dive deeper into some of these different areas. So as I'm going through the software or some of these concepts, I want you guys to be submitting questions in the chat or within the question area of the platform here. I'm not sure which way it works. And that way I can tailor additional webinars to you guys and what you want to learn about and what you want to understand better. Part of what the software does is help simplify in the term or in the way of building a very complex definition out into an algorithm, right? So an algorithm is a pattern of steps given a certain scenario that will lead you to a particular outcome, right? So this definition for medical necessity, I want to take you through this because it is very nuanced, it's very thorough. And it says medical necessity refers to a patient-centered determination of the most appropriate effective treatment option for each individual patient made by a treating provider in accordance with generally accepted standards of practice that are evidence-based, evidence-informed, or services based on a consensus advisory opinion recommended by recognized healthcare professionals are necessary to remediate, rehabilitate, or ameliorate the symptoms of the symptoms and other effects of diagnosed conditions in order to enhance health and safety, improve overall functioning, and prevent deterioration or regression. That's one sentence. Sentence number 2, medical necessity determinations are not made primarily for the economic benefit of the health plans and purchasers or for the convenience of the patient, treating provider, or other healthcare provider. Okay? So that is an extremely comprehensive definition for medical necessity, which you are beholden to meet in order to get reimbursement through insurance and other funding sources that operate in a medical model in order to treat individuals with autism. Okay, so what the algorithm that I've built internally within the software, and this is part of the goal development module. I like to call it, for short, the MNC sandwich, medically necessary care sandwich, right? So the sandwich has got 2 pieces of bread, right? Bread number 1 piece is that it has to be tied to an assessment, and bread number 2 piece is the outcome, that it has to be socially significant, right? And then in between those 2 pieces of bread, you have to put at least one of the fixins in there, right? And so you could have 2 of the fixins, all 3 of the fixins, or just one of the fixins, any combination of the above, but you have to have at least one. And the least one is either it prevents further regression, 2, it ensures health or safety functioning, or 3, it allows for further integration, right? So based on how you select within the software these 3 things, it's going to give you an output that actually meets this criteria. And then also, again, in lines with the standards of practice, be clinically appropriate, not primarily for the convenience to the patient, not primarily for the economic benefit of plans or purchasers. Does anybody have any thoughts, dedications, requests so far? I'm just going to check in over here. I'm the only face that I see. That's great.
Yeah, and if you guys have any questions, post them in the chat. This is awesome though, Mandy.
Oh, thank you, Derek. Appreciate it. Right.
And I want slide 4. I want that illustration from slide 4. That is brilliant. I know correlation doesn't mean causation, but it is interesting to see those things mapped out together and how they may relate to each other.
Yeah, I've got a white paper that you can download from nonbinarysolutions.com that has this illustration and the whole talk that I give about this phenomenon. So feel free to log on over there and download that so you can have all that information.
Definitely will.
Yeah, it's also on YouTube if you want to bother listening to me even more today. Anyway. All right, let's switch over here. I'm going to take you over to the actual software at this point. So this is the inside of my user dashboard as a clinician, and we're looking at my patient here, Billie Eilish. You're welcome. So what we've got here is a dashboard, whether we want to start a new module, or you see here that I've had goal development, which is in beta. I've saved this as a draft so we can quickly go through it. Uh-oh. Well, guess what? Just got kicked out, which is great security, but might have messed up my entire demo.
I was going to say, I'm happy that you have good security that's not letting you just stay signed in for a long time. It's beautiful.
Thank you. Oh, it still saved it. So yeah, good news. All right. Yeah, so this guy, goal development, again, you see that it's been saved. I've gone through it all the way, so it's 100% complete. And so here also is the care navigation module, and we've only done part of that. So again, within the sequence of the software, you have to do a care navigation module first because that is the intake. That is how you actually build the patient into the profile so that they show up here. So you see we've got Billie. We've also got a second patient here named Michelle Dawson. So we'll go back to Billie, and I'm going to open up this care navigation module so you can see sort of how this all starts. And so I filled out part of this so you don't have to get bored watching me type, but it's basically a way of training your staff or yourselves into a clinical interview, right? Being able to go through all this stuff. So, if I'm the user, I'm saying, tell me what your name is, and this person's name is Mary. And so I can add a guardian. We see that we have already added Mary in here. So we've got Mary, her name, her age, her bio, nickname, so on and so forth. We've got father number 1, who is Bob, 47 years old. He's biological dad. Nickname is Dad. If I wanted to, I could go in here and add another guardian. So let's say we've got a grandmother, right? And grandma's name is Ruby. Type, biological grandmother. Age, we can say she's 77 years old. And we can call her Gran, right? So that's how we can add another guardian into the situation. And so from there, just basic information, email, phone number, so on and so forth. Who has medical decision authority? This is an important question. So again, background, this is 26 years of me doing all of the intakes for every patient that came into my clinics. And so every time there was a situation where I found something out 6 months or a year down the line that I realized I should have asked about that at the beginning of services because it would have changed a lot of what I understood about the case conceptualization. This is one of them, right? Who has medical decision authority? I guarantee you a lot of young clinicians probably wouldn't think to ask that question, but it comes into play in certain scenarios down the road, right? If there's an emergency of some sort, somebody has a seizure, etc., the paramedics are here. Who actually has medical decision authority whenever you ask for those types of information? Does the client reside in more than one household? So currently what we've got selected here is no, but if I select yes, then you can see that it changes the way the decision tree moves in the background, right? So if I say yes, then it's going to ask me how many households, and primary residence is mom and dad. Oops. All right. Are there any legal agreements regarding custody? So again, if we would have a biological mother and say a stepfather or stepmother in that situation, we may have a legal agreement. And if that's the case, then I want to know sort of the details of that custody arrangement. And there's also a place for you to upload any kind of documentation related to that. So again, it's right here in your patient portal. You already have that information if it were to come to a situation where you needed that information right away. Is there more than one language spoken in the client's home? This is a frequent issue, right? So how many languages? If I say yes, it's going to ask me how many languages does the client speak. If I say no, that goes away. So back to yes. I say 2 different languages. What is the primary language? English. What is the secondary language? So on and so forth. Do they have preferred stuffed animals? Describe the stuffed animal. Do they have any preferred reinforcer comfort items, as Billy loves to spin? Do they have any client favorite games, etc.? Please add any additional notes regarding the home environment here. So it says Billy's home has chimes and alarms on all doors and windows due to a history of elopement. So that's something that I can put in there as I'm interviewing the family. So I want to know about primary care physician. It's Doctor Who. Have they ever received or is receiving any kind of therapy? If I say yes, then it's going to give me these drop downs. If I say no, then they're going to go away. So I say yes, I checked off speech therapy. How often are they going? On what days are they attending? At what time is that speech therapy? And again, if you have a speech therapy report from that provider, you can upload it right here. Does the family have to adhere to a strict routine, right? So in some cases, the answer is yes. You know, the child always has to leave at such and such time of day, or they always have to sit in the car seat in the back right of the car and not the back left of the car. You know, anything related to an insistence on sameness that may be common with individuals with autism and their families, right? So you, again, if you say somewhat, you can add notes there, what's going on. Has the client ever received ABA therapy in the past? For how long did they receive that ABA therapy? When was the last date of service? Where was that ABA therapy received? Do you have any kind of provider discharge report or anything like that? And again, you can upload that directly into the patient record. Okay, so here we've got an area that we call sort of significant history, right? So it's got a series of questions about hospitalization, history of suspension, aggression, self-injury, property destruction, so on and so forth. And so when you go through these questions, it gives you a drop down. And so the possible answers to all these different questions are no, there is no history of the thing related towards behavioral and mental health needs, right? Or yes, but we have no additional supports in place following that thing, or yes, and we are in the process of putting supports in place regarding that area, or yes, there's a history and those issues were resolved and supports are currently in place for the area of treatment moving forward, right? So if you say no, it's just going to let you move forward. Same here, history of suspension or expulsion, aggression, and here we chose yes, those issues were resolved and supports are in place for that area of treatment. And so you can put your notes in here. It's like, what was the area of property destruction? What are the supports that are not now in place? And let's say you had a behavior plan related to that or any kind of data that you wanted to upload, you could upload it right there into the question as well. Okay. Okay. Has the client had a full multidisciplinary diagnostic evaluation? If you say no, then we want to know who is referring for that multidisciplinary, right? And if you say yes, it's just going to let you move on. What are the client's diagnoses? So you can add any of those there. Do they have any medical diagnoses? If you say, I don't know, or I know, or if you say yes, it's going to give you a drop down and ask you for that information. If you say, I don't know, or I know, it's going to let you move on. Any concerns related to vision or hearing? Any concerns that have not been addressed medically? If you say yes, it's going to ask you, please describe the concerns. And so here I've put in that we've got some concerns about bowel issues for this kid. Then it's going to ask you to add any medication. So here we've already added Zoloft. It's going to ask you, is the client taking any medication for any of the following conditions? And so we've checked off anxiety there. Has the client received anything regarding access to care? If you say no, meaning that they have not gotten access to all the care that we think they need, it's going to ask you why not. And part of what we're interested in learning about these patients at this point is understanding their social determinants of health. What are the things that are getting in the way of them accessing their care? So is it cost? Is it waiting lists? Is it behavioral barriers? Or is it all three? If you say behavioral barriers, or I'm sorry, if you once you answer that question, it's going to ask you which types of medical access you're not getting. So maybe there's a test that you're wanting to have for the patient and they're not able to do that. And then you're going to have some notes here related to why it is that they are not accessing the care at this point. Okay. Is the client in school? If you say no, we're going to ask why not. So we'll say that they're homeschooled. Does the client have any of these strengths or interests? So maybe they have a specialist knowledge of topics or areas. They have great attention to detail. Let's just say those two things for now. Describe their play. We'll say that they're mostly solitary, sometimes just mostly solitary. And then any other notes that we might want to make about them here. Has a client ever run away from the caregivers? This is an important one. If you say yes, then it's going to ask, do you need utilize special locks or processes to keep your child from leaving the home? If you say yes, then it's going to ask you to describe. Any clients? Does the client lack skills that pose harm to themselves or others? Any history of restraint or seclusion? And I'm just going to sort of quickly move through these guys so you have an idea of where we're going. Can the client request at least 25 separate and distinct items? If I say yes, that's going to give me a pretty good indication, regardless of the age of the person, of their level of communication skills. If I say no, it's also going to give me some information, which again will go into our intensity. All right, so let me just give you the punchline here. What this whole thing then generates for you is a care navigation report. So after you've entered all that information, it's going to type all of this information out for you in prose. And so you can download this as a PDF. You can print it out. You can hand it to the parent. You can submit it to the insurance company, so on and so forth. But what it tells you is the basic demographic information. And then right at the top of the report, it's going to give you a recommended action summary. So these are things that, based on how you answered the questions within the care navigation module, it is indicating that we think you should do either prior to beginning treatment or concurrent with beginning of treatment within an applied behavior analysis. Because a lot of these folks are just sitting on a waiting list within the organizations. And so we think of this as something that parents potentially could go try to get accomplished between now and the actual start of services. Or in some cases, it's recommended that those things are taken care of prior to beginning services, right? So some of the actions that have come out of this older module that I already completed with Billy says that, hey, we're recommending the follow. And keep in mind, folks, this is recommendations. This is not, you have to do it. This is not making decisions for you. This is just an algorithm that says, these are things that we think would be beneficial. So it says, Recommended that the following referrals for evaluation be made prior to scheduling an initial assessment. It says a full multidisciplinary and diagnostic evaluation, a medical evaluation or rule out for a medical diagnosis, a medical evaluation for any other concerns, verify if the individual education plan is required, conduct an augmentative communication evaluation. We want a sleep evaluation of some sort to rule out biological issues with sleep or possible seizure disorders. And we also recommending a feeding evaluation by a medical professional. And then here you see it gives you a different report, or based on how you answer things in the previous model, it's going to give you the sort of recommended, this prose written report about what you said, right? And this is, again, this is not directly from the one we just did. This is an earlier one that I did. So the information inside looks a little different than how we just answered some of these questions. But you can see that it sort of highlights all that information for you. And then you get sort of a profile summary. It says Billie Eilish is a 5-year-old. It's been diagnosed with autism and OCD. The diagnosis was received from Dr. Who, and a multidisciplinary evaluation will need to be completed. Since it is unknown if Billie Eilish has any medical diagnoses, it is recommended to conduct a medical evaluation or rule out. There are no concerns related to vision or hearing. Billie Eilish is currently prescribed the following medications and managed by the following providers. So we see there Zoloft 50 milligrams taken daily by Dr. Who. Some of those medications listed are prescribed for anxiety, and Billie has been able to access basic care needs due to waiting lists, right? And then we get an educational history, strengths and interests, and then a summary about their behavior and communication, sleep issues, eating and feeding issues, toilet training, and any of the additional files that have been uploaded into the system are then listed here in this report. So this report, again, now lives in Billie's patient record. And so we're going to go over here, again, save this as a draft, go back to Billie's documents. So here is that care navigation report that we were just looking at. Okay, so again, that's one that was completed earlier, not the one that we just saved as a draft. So you can see that that lives in the patient's file. And so here comes this guy. And this is who we call No Yeti. So it's a little Sasquatch looking character. We like to say that he takes the mystery out of treatment planning, right? Anything that is in Billie's patient record in this file folder over here that we see, including this report, No Yeti can now chat with you about that, okay? So this is just like a chat GPT, except it is not on the internet. It is in its own fence on our software server only. And so it does not hallucinate with outside information. All it knows is what is inside Billie's patient record. That's it. So I can't ask it about Michelle Dawson, our other patient over there. It would not be able to answer any questions. It would not be able to mix the two folders, right? So it's only going to be able to answer questions about Billie, her primary physician. It can answer simple questions. It does not make recommendations, right? It is not like predictive about anything. It's only going to answer information from the source, right? And part of what we're asking people to do as they use this technology with us is to give us feedback. Like, was this a good answer, knowing what you know about this patient, right? And so you can look specifically to see where this information is coming in from the patient record, so that way you can verify that it is actually correct. Because again, we don't want to just blindly trust software with some of the recommendations or some of the answers it's going to give us, right? And then we ask for feedback from the users. Do we think this is a good answer or a bad answer? If I say it's a good answer, it's going to get that feedback to our team. If I say that this is a bad answer, which I'm not going to do right now, it brings a follow-up question up and says, okay, what was bad about this answer? What didn't you like about this answer? So that we're getting feedback from our users about what is actually useful, what is not useful. Or is it coming up with information that is not accurate? And do you think that this is a recommendation that we should change somehow, so on and so forth? And so think about with, again, the ability to upload all of the different patient records in here. Right now, it's just asking, or it's just reading through, if you will, this care navigation report only. I can go in here and upload another document. So I put together a fake treatment plan for Billie Eilish over here. So I'll take this, see if I can drop it in, do it this way. Fake treatment plan, upload that. So now you see this fake treatment plan is also in here for Billy. And so I can say, see if it answers this correctly. Okay, so this is the answer that it's going to give you when it doesn't understand either the question or if it doesn't believe that the documents that we have in there are actually going to the information, right? So it's sort of, that's its blanket answer for you. Like if you were to say, who is George Washington? There you go. My only purpose is to answer questions about the provided documents, right? So again, it's not going to be able to hallucinate. It's not going to be able to answer questions that it doesn't actually have information available to it. Let me see if I go in here and look at this.
Can I just say something? It is such a difficult thing to run an AI system that doesn't hallucinate and to just zoom it in on that one area. Like this is your knowledge base, and to use the machine learning to just focus in on that and answer specific questions. That's a pretty huge technological feat in itself. Like pretty awesome.
Oh, thank you. Yeah, we're pretty excited about it. But and again, I mean, we released this module in November of last year. So we did a lot of training up to the release, but what we are specifically looking for is our lighthouse customers, our early adopters to come in and help us train the AI model so that it can get better and better at extracting this information from different plans, right? Because it's very, very good currently at being able to find information within this care navigation report because that's what we trained most of it off of. So it knows exactly where to look for all the things that are in here again. So if I go back here and I say, let's go to Knowetic and say, what are the recommended actions? Here we go. So it knows exactly where to go in and find the information in that report. But, if I uploaded an 88-page treatment plan from, let's say, Optum or somebody specifically that has specific format to it, it might have more difficulty going in and looking for specific information right now. But if we work with our customers to train it to know where to look in those reports, it'll just keep getting better and better. So again, the software is learning based on how we give feedback, and that's why we're asking our customers to use these sort of answer source and feedback buttons to let us understand what's good and what's not. Blood medications.
Early adoption is the key here, people. Get into this stuff and start working with it now, and let it learn from you, and you will learn from it, and that relationship will just build. It's almost like an employee. Like
That's
it's
right.
the same kind of like that entity will get better and better as time goes by, and that's the whole concept behind the machine learning. It's awesome.
Right. Yeah, and so think about if you've got a caseload with one BCBA, that BCBA quits, and now you have to hand their caseload off to another provider or several other providers. Think how much faster your staff are going to be able to get familiar with a case if they're able to go through and chat with that person's records, with their treatment plan, with their goal bank or whatever the thing is, right? Instead of having 45 emails back and forth between me and other staff members about who this person is or their background or their history, I can simply ask Knowetic about all these things, right? And again,
And it comes down to continuity and consistency too, like doing the same thing, right? Being that consistent care delivery medium that's what you want in your business. You want to, have consistency where what if a BCBA is out on medical leave for 90 days and somebody needs to take over their cases for a while and then they come back, like, having it, uniformity and consistency and business continuity. This is huge for that, for all those things.
Absolutely. And again, just having all those different types of records at your fingertips as well, whether it's a custody document or an IEP or speech therapy document, so on and so like all of that's going to be able to live in one space. And so the other thing that we're doing, currently with this product is we're starting to partner with other data collection and EMR groups and have our APIs handshake in the background. So that means that information that I input here about Billy, all the things in her within that within that care navigation module that has all of her basic demographic information, that would be able to automatically get pushed over to the data collection or EMR app. So you wouldn't have to repeat keystrokes. Or in other cases, if you already have that information in the data collection or EMR, then we would be able to pull it into Knowetic as well. So again, sort of eliminating that back and forth to have to do things twice in two different platforms. And that's again, sort of where this is going, is that you'll be able to have all that information in one space that has a complete digital sort of ecosystem to get feedback on it. Let me look over here and see if you guys have any questions, dedications, requests.
Oh, Arianella was saying that she started using AI on Facebook, but hasn't considered it for her ABA business. And I will say that there's two, from a business continuity and security and stability standpoint, like I am always looking for ways to make our information, our data redundant, right? So like separate systems, they can be integrated, they can be connected, that's fine. But, I'm generally okay with seeing somebody make a few extra keystrokes to have information in a place other than your data collection or other than your practice management system, right? Because when we do tabletop exercises, we're talking to our BCBA owners, about what if you come into work tomorrow and central reach is down or rethink is down, and what if you can't get in for the next 30 days? How are you going to continue that service delivery? And I know it's going to be a pain in the butt, you're going to have to go back and re-enter stuff or whatever, but you don't want to go from 100% performance to 0% just because one part of your system is missing, ever. Because they all go down. Amazon could go down, and that's going to take out a whole bunch of SaaS providers, right? So it's important to have that redundancy anyway, even if you do have to do a few extra keystrokes. Like that's not as big of an inconvenience as being down for 30 days. And if you have that sort of infrastructure, and Knowetic is good just for that, just to have it in another place and have that quick reference where it's also supplementing your consistency of delivery, your business continuity, making sure that everybody's on the same page on your internal team, and also making sure that your client interactions are consistent. It's really a great tool. This is awesome.
Thank you. Yeah, and it's worth noting there, if you said you started using AI on Facebook but never thought about it for ABA or my business. Again, what's very specific about this chatbot is that it is HIPAA compliant. It's in its own fence. It's not taking any patient information out to the internet, right? So all it's done is borrow the architecture, the engineering behind how large language models work, and we've put it on its own safe HIPAA compliant server, right? And so you would never, ever want to put any kind of patient information into ChatGPT or any of those other online LLMs, right? The large language models, because that would be a HIPAA violation. So just a word of caution to all the listeners out there.
So how are you doing that? Are you running this on Azure or AWS, or where are you hosting that app?
Yeah, it's AWS is where it's being hosted. Brilliant. Yeah. And so we have a BAA, a business associate agreement with AWS and with all of our customers. And so that's sort of the legal protection behind how everybody is able to operate with patient information in this kind of sensitive setting, right?
And also zooming in on the specific, and so what level of trainability is there? How broad can this AI be applied to the business? we know what data it has access to, but what areas are we getting into? Is it just the clinical delivery, or are there billing modules or anything like that that can be a helpful thing for session notes or anything like that? Or I understand you have your lane, you want to stay in it. I was just curious as to what's coming and what other uses there are.
Yeah, I mean, we've got a pretty robust product roadmap. We're trying to get these first three modules out the door first and really be able to raise more money based off of user feedback and traction with that. But like we've already built the architecture for an organizational chatbot, right? So rather than a clinical chatbot, we've got the organizational chatbot, in which all you do is upload your employee manual, your policy and procedure manuals, right? Your scheduling cancellation policies, any of those types of documents, right? And now what you can do is hand it to your new employees or your current employees, and when they have questions about policies or procedures, they can just chat with Knowetic, right? They just say, hey, what's our cancellation policy for less than 24 hours? Or how do I request time off? And it would instantly tell you within your organization what the rules and procedures are.
Are we open, or are we working on Memorial Day, right? So
Yep.
like this is something that you want to, as a business owner, we're always talking about your source of truth. And when I say source of truth, people are like, what do you mean source of truth? What is your source of truth? If you as the owner are the source of truth, that's why your phone is blowing up all day. Right?
Yeah.
Like that's why your employees are calling you all the time. If you are the source of truth. So you need to take what's in your mind. Your first step is to get it documented, right? Your next step is to have a system by which you're updating this documentation and keeping it fresh and keeping it up to date, right? Where it's real and it's compliant with new regulations and new changes and new delivery models and all this stuff, right? But the AI layered on top of that as the organizational bot is so powerful because, in 2013, I set up my source of truth in a searchable document library where I wrote, 300 pages of documentation where my employees don't have to call me and ask me anything anymore. They can just go to SharePoint and search it. The AI concept there is a whole different level where you can almost talk to a person, right? Where if you can take your CEO brain and put it into a chat bot and use that chat bot and like, did you ask? Like, you're calling me, but did you ask the bot, right? Whatever you name it in your company, it should have a name so you can refer to that person. But it's really a brilliant use of AI, and the fact that you haven't zoomed in on specific clients and you're preventing hallucination, because that's hard. Who is George Washington? And for it to zip its lips and say, I'm only talking about this one thing is a you guys put a lot of work into making it do that.
Thank you. Yeah, we want to make it effective, right? And to your point, sort of call to action here. Come check us out. We've again got a really early lighthouse customer rate that we're bringing people on board because we want feedback more than we want money at this point. But yes, come build this with us, because part of our whole point here is we want to build this collaboratively with the clinicians, with the field itself, right? We don't want to impose some solution on you. We want you to feel like what we're building for you makes sense, right? So we need your feedback. We want to know what's important to you, whether you like the information that you're getting from it, whether you like the interface from it, so on and so forth, because AI is coming, just like the graph that we showed early with the internet and what happened in 5 years when the internet was adopted, right? That's where we are as an inflection point now with AI. Like, it's going to change the way that we all fundamentally operate in society. It's not coming for your jobs, right? It's not going to replace anybody. It's going to enhance what you do. So rather than think of it as artificial intelligence, think of it as augmentative intelligence, right? You're going to be a bionic therapist that can now think faster because algorithms are available to you to get you the information that you need, right? I always like to tell the sort of analogy here is that the first time somebody tries to solve a Rubik's Cube, it takes them an average of 4 hours, right? When you get to be a speed cuber, you can solve those algorithms in 5 seconds or less, right? And that's what this software does. It takes you from a 4-hour thought process to a 5-second thought process.
Yeah, and it's just the fact that it can do it so much faster than you can, and we call them EBCBAs, right? The entrepreneur BCBA. You're always looking for ways to retain your employees, to make their jobs easier, to prevent burnout, to prevent that daily grind. We get back to what it is that they want to do, which is being in front of the kiddos and helping them in their lives, right? Not doing paperwork or researching stuff or whatever. Like, you just want to help the kiddos. This takes your time on the other stuff down a bit and helps you to focus on those things, and also, help to improve the outcomes. So how do we get involved and start sending you money and feedback to help you start building out this tool? What do we do to become a client?
Yeah, so I'll put this in the chat for you again. It's just Knowetic.ai is our customer facing page. So you can go on there and click through to sign up today. If you have questions, dedications, requests, I am easy to find on the internet. You can find me at amandaralston.com, nonbinarysolutions.com, or Knowetic.ai. I'm also rather prolific on social media, so I always like to say that I'm vaguely professional on LinkedIn. I'm mostly authentic on Instagram, and I am completely unhinged on Facebook with memes. So buyer beware. Choose carefully what you want to actually follow me about. And thank you very much, and you're welcome.
But what does it cost? So what does it cost to do it? How do we, so we go to the website, we get on there, like, what kind of programs do you have so we can start getting involved?
Yeah, currently our Lighthouse customer program, we are charging only $39.99 per month per BCBA user. So this is designed for BCBAs currently, or leading senior clinicians, right? This is not necessarily for RBTs, because you need to be a decision maker at the moment for the software. But yeah, $39.99 per month per user. And yeah, it's relatively easy just to click through the process.
And on your roadmap, is that pricing set to change later and probably go up as you're adding features?
Yes, it will, but not for the Lighthouse customers. So if you get in early, you're going to lock in pricing for 2 years.
That's brilliant. Yeah. So this is the benefit of being an early adopter. And yeah, so everybody who wants to tweak your business a little bit, give you that competitive edge. I always say, you can do your data collection stuff. You could do it on paper, but electronic practice management data collection is a thing, and you're not going to be able to compete against that on paper. And very soon, Knowetic will be the same. You will not be able to perform at the same level without it. So this is a great thing. Mandy, thank you.
Thank you guys so much for having me. I appreciate it.
Thanks everybody for showing up. We'll see you all in the group.
You're already doing the work, investing your time, your energy, and your vision. So let's make it count. Build something that works without breaking you. The EBCBA Blueprint is the way. Get started for free with our foundation course.